Good evening, and welcome to this special edition of Doctors on Call on the COVID-19 epidemic. I'm Dr. Paula Termuhlen, Regional Campus Dean at the University of Minnesota Medical School, Duluth Campus, and I'm your host again for our program tonight. We're continuing this series of special programs to answer viewer questions about the coronavirus, and I want to thank everyone for sending so many in advance. With the situation changing every day, we want to bring you the latest information to help keep you and your family safe. I also want to reassure everyone that we're sitting 6 feet apart and that our WDSC staff is taking excellent care with us. They all have masks on and there's fewer than 10 people in the building tonight. The telephone numbers and email address for your questions can be found at the bottom of your screen. Our panelists this evening are Dr. Ken Ripp, a family medicine physician with CMH Raiter Family Clinic in Cloquet, and Dr. Nick Van Deelen, St. Luke's Chief Medical Officer and ER physician. Members of the WDSE staff are standing by to take your calls and emails. And so we're going to begin tonight with some questions that came in through the week to start off the show. So Dr. Ripp, I have one for you. One of our writers wants to know, as a person who's in her 80s, she has a friend who's also in her 80s, and they've both been isolated without contacts in their home for the past 15 days. So our writer wants to know, is it safe for her to socialize?
That's a difficult one. They're probably both COVID-free, but you just don't know if they were exposed by a visitor or someone else. And the best thing would be is just to follow the orders, stay apart, wait till the all clear is given. And hopefully that will come, it will seem like a brief period of time and they'll be able to get together. But to be safe, I would think that it's probably best that they stay apart.
Okay. So, Dr. Van Deelen, we've had several questions through the week on folks that are curious about the hospital experience right now. So if someone has to go to the hospital, what can they bring in with them? And how are you managing the anxiety with families who aren't able to connect with their family members? Maybe just talk a little bit about what you're doing at St. Luke's around visitors.
Sure, thanks Paula. And it's, I would say it's not just St. Luke's. We've tried to establish really a community standard for certainly visitors to St. Luke's and to St. Mary's. So what we're trying to do is we're trying to protect our patients, many of whom are vulnerable, and also protect our staff so they can continue to provide care. We have limited visitation, really no visitors, unless the patient happens to be a pediatric patient, so we allow one, or in the case of the delivery of a baby, we would allow one. Now there certainly are special circumstances where maybe a patient requires help communicating or somebody to advocate for them. We do make exceptions for that, and certainly in extreme circumstances where somebody's particularly ill, we would make some concessions for that. We know how important it is for our patients to have access to their family members. So we have tried to optimize, just like at home, using iPads and phones and helping our patients be able to communicate with their family member or loved one. And we're in the process of setting up a family assistance center that's on campus but not in the hospital to help support that process.
So, and that's really good to hear, because a sort of secondary question was around how are families able to be consulted around decisions. So it sounds like really utilizing some of the electronics and then creating some help with that.
Absolutely. And
okay.
I think our providers too are aware of how important it is to invite families and engage them in discussions of care for their loved ones. So our providers have moved towards a pattern of reaching out to the family member, again, as the patient requests, so that that line of communication stays open.
And Dr. Ripp, now, and you're in Cloquet,
yes.
And so we were just talking about entering the hospital. So can you give us just a quick flavor of what it feels in your neck of the woods?
And so we had a hospital with multiple entrances for a nursing home, and so now it's been really redirected. Anyone who is critically ill come through one pathway through the emergency room, but all staff have to go through one entrance, and everyone is screened with temperature and the questions, and then it can happen even as I go from the hospital over to my clinic. I go through the questions again, they check my temp again, and so we're trying to screen everyone, and then as people come into the clinic, we're doing screening on everyone who comes in.
So even as a physician and members of the staff have to undergo a screening process before they're able to enter the building.
Yep.
Very good. So here's a general question I think either one of you might be able to attack, and it's a little bit about, it goes back to that, our first question around the contact. So one writer asked, how is it that we're starting to see cases in people who are in prison or in some of our elder homes here in the Duluth area, they're getting infected even though there haven't been visitors for several weeks? What's going on?
Well, I think it's really an example of a few things. One, the infectivity of this virus. Two, the fact that we know we have established community spread in the state of Minnesota, and that many people can be very, if not asymptomatic, minimally symptomatic. So I think we would be surprised who has this illness.
And in the spread, the prisons are not necessarily a closed system in that you have visitors, you do have guards who come in and out, but you also have prisoners who get sentenced, and so they're in jail and so they could be infected in jail and end up going to prison and bring it in that way.
There's a lot of transfers of people.
A transfer in, a lot of movement of people within the prison system.
Yeah, I think we've been giving this a lot of thought in my household. My husband works at a facility here in town and is working regular hours, and I'm in and out of the hospital. University, we're all working from home right now, but for those of us who still are working in the hospital. And so at various points, even though we're taking all the precautions, either one of us could be exposed, and then the next person gets exposed.
Yes.
Yeah. So, Dr. Ripp, another question that came in this week was around elderly people, and is it a good idea for them to get the general flu shot or the pneumonia shots to prevent any illness there?
This is definitely, if they are not up to date on their immunizations, they should be up to date. Our hope is that in as quick a time possible, we have a vaccine against this disease. That is our hope. There's no guarantees. It takes a long time to work out these viruses to make something that works. But the flu shot really helps protect people, and the pneumonia shots have been very helpful of keeping people out of the hospital. The hospitalization rates for pneumonia have gone down from the vaccinations, and so they're tremendously helpful.
I think what we probably don't know is whether or not the pneumonia shot helps someone who might have COVID-19, because there is a pneumonia associated with COVID-19, or there can be.
Yeah, I'm not really aware of any literature that would say that a pneumonia shot is protective, because this is such a unique disease, and what it does to the lungs is different. These patients are not dying from a bacterial superinfection, they're dying from the primary infection.
Okay. And just to be clear for everyone, the flu shot that we think of that we start getting in the fall is not effective. We don't have any vaccinations yet for COVID-19. And I don't know what you've all read, but I'm hearing somewhere in the neighborhood of a year to a year and a half for something like that to be able to be available.
That's my understanding.
And why that is, it's a new virus that we've never seen. And so we can't create any, we have to start from the building blocks and science it all the way through to a vaccine. It's going to take a little while.
And we have to test it, right?
Yep.
We have to test it in humans for protection. I think another thing that people are hearing a little bit about right now are these sort of home tests or antibody tests that might are starting to come onto the market. I'm hearing some variability about what people are thinking about that. Dr. Van Deelen, I don't know if you've
I think
got some thoughts.
The challenge, and I think Dr. Ripp alluded to this, is it's a completely new virus, so the testing also is new. Every test has its own characteristics in regards to accuracy and false negative or false positive rates, and I think we are challenged with that generally in regards to the testing. I think also some of the testing, the blood tests that we're doing, it might show that you were exposed. We really don't know that being exposed necessarily confers immunity, meaning you aren't going to get the disease if you're exposed again. So There's a lot of discussion about what that will mean as we try to get people back into the workforce and think about relaxing some of the social distancing interventions. I think the jury's still out on that.
Yeah. I would say one thing I think I'm particularly intrigued by is how rapidly testing now, at least for the patient that we're concerned about, is now starting to ramp up. And I thought maybe the two of you could comment in your own experience how that's going for you right now. If you have somebody you need to test, for example, Dr. Ripp?
So we're still not testing freely. We're still sort of picking people who we're really concerned about, who are in the hospital that we're worried about getting sick, and those ones who are testing. The turnaround time has sort of waxed and waned. So when Mayo Clinic began to test, we got a turnaround in 24 hours, but now they're back to a couple of day turnaround time. So it's not an instant test. And for us, it's hard because you have a patient with a test that we tested, and we're sort of holding our breath. We're doing all our extra precautions with them until we get it back. Now, fortunately, our small hospitals had negatives, but we're definitely looking for it.
Yeah. Dr. Van Deelen?
Yeah, we're challenged with exactly the same thing. We up until really this week, all of our testing has been sent out to the reference lab, MDH, the Mayo Clinic, and Hennepin County Medical Center, and we adhere to the same kind of criteria that Dr. Ripp was alluding to. And the turnaround time, it shrinks down, and then the criteria is opened up a bit more, and then the days for turnaround climb. We this week now, for the first time, will have the ability to do the test on site at St. Luke's. The turnaround time will be quicker. Again, the problem that we're running into is that we're only getting a small allotment of the kits to perform the test per week, and we believe that's because these supplies, like other necessary supplies, are being sent to areas that are true hotspots right now. So despite the fact that we'll be able to do it and the turnaround will be quicker, the small numbers will mean we're going to have to stick to that limited criteria for testing.
Very good. So let's turn to the virtual visit, because that's a new experience for a lot of people. It's actually come up on the last couple of shows, and I have also delivered virtual visits with my patients. And so one of the writers would like to know if when you're virtually visiting a doctor using a patient portal or even texting, is it as effective as using Skype or another visual communication? So maybe we can just talk a little bit about virtual visits.
We rapidly had a transition to offer this to our patient population. It's not ideal. That face-to-face interaction is always a little bit better, but it is unique, and you get to see a little bit about on their background and what their house looks like and how they're looking. And most patients are surprisingly good at it. You can glean a lot from it, you can get a lot done, but you cannot, the physical exam portion is pretty limited. And what was the other part of the question?
Well, I think really it was about the idea of is it okay to be on the phone, or is it okay to be through a patient portal versus a visual? And I think you're alluding to the idea that visual gives you a little something extra.
Yeah, I mean, the video conferences and the video technology, depending upon the patient's reception and our clinic's reception, can be actually fairly good, but the exam is limited and probably a little bit better than a telephone encounter where you're just talking on the phone. So,
yeah. I would add, it's no substitute for the human interaction that is the foundation of medicine. And I think that that being said, I believe that the video does add something significant that a phone call or working through the portal does not allow for. I think the other, and I think the different platforms that are used in regards to video, some work better than others too, and so that's been kind of a process at St. Luke's to try and vet these different resources to try and identify what works best for our patients. I think the other thing we have to remember too, and we did such a good job early on saying, we don't want you to come into the hospital unless it's absolutely necessary, or the clinic for that matter. I think that folks have done such a great job with that, and we've really expanded our ability to provide these virtual visits, these telehealth visits, and yet we know that there are a significant portion of our patients who really do need that face-to-face visit. And I hope that patients remember that there are reasons to go to the hospital yet, and please do.
Well, and I'll just share my own quick story as a patient I operated on who has a question about her incision, and it's in a place where she can't really give me a photo because of internet connections and so forth. And she's trying to describe it to me, and I'm like, I really am going to need you to come in at some point, and I think that's, I think that's a challenge we all face. That visual makes a difference.
Well, so I'm an emergency physician, and our volumes across the board have been down throughout the state and at St. Luke's. And if you look at the level of illness that our patients are coming in with in the emergency department right now, it's significant, which suggests to me that people are maybe waiting a little too long. And I think that's the other message, is that as we've kind of learned more about this virus, I think we're doing a better job of keeping potentially ill patients away from some of our more vulnerable patients. So I think it is safe to go to the clinic if you need to go to the emergency department if you need to. Certainly call your clinic and work through them. They can give you good guidance in that regard. Great.
Well, we have some callers that are very interested in a couple of areas that I think we can all sort of chime in on here. So we have a caller from Cloquet who'd like to know if we should be washing all of our produce.
Yes, I mean, that was a recommendation even before for anything that gets on your produce and stuff like that. So I think that is a very reasonable thing to do.
So and it's interesting, we have an individual from Hayward wanting to know if the virus would die on canned goods if they've just been sitting around and not washed. And I think so that just sort of opens up a whole, we've talked about mail, we've talked about a variety of things. I think my understanding has been that if you want to be totally cautious, you have to leave things for 24 hours. But for the most part, it's, things that you're getting at the store or your mail and so forth are not seen to be as, there isn't as much concern about taking those things home with you. But the produce, we should be washing our produce anyway, because there's other bacteria that can be on the produce, right?
And I think the key point is we know this virus does live longer on some surfaces than others. We know it does better on, for instance, on a metal surface, a hard surface, than it does on textiles. But that's where hand hygiene is so important. In addition to the social distancing, the hand hygiene piece will.
Should have a big bottle of Purell.
That's right. That's right. Well, we all gooped up before we came in tonight.
Did, yes.
So, we have one person who wrote in this week that was curious about how are the rooms being cleaned and equipment at hospitals. And is that the same as in the clinics? So Dr. Van Deelen, I'll hand hospitals to you and let Dr. Ripp talk about the clinic.
Yeah, so we have, and this is part of our mitigation plan and preparation for COVID-19. We've kind of reevaluated all of our cleaning procedures. We've used information from CDC and MDH, but also from areas in the country where they've been dealing with this. And we feel like we've had to make some subtle changes to our cleaning procedures. Most of that's around specific types of procedures that might result in more what we call aerosolization of the virus. And we feel like with those slight tweaks, we are able to keep the hospital clean and safe for our patients.
Anything different in the clinic?
We're doing definitely more surface cleaning all the surfaces. There's a lot more wiping down. Because the clinics are a little bit slower, because we're keeping a lot of the routine visits away, people have more time to clean. And so people are just cleaning everything. We've pulled out some of the, we've I'll say it, uncluttered some of the rooms, taken things out of the rooms, some of the toys for the kids, we've taken those away, and just made a much more cleaner environment, so there's just not enough more things for virus to sit on.
Well, and we had one of our faculty from the medical school on a couple of weeks ago who explained to us that the virus is actually coated in a fatty layer, and that soap disrupts that fatty or lipid layer very well, which is why just general cleaning supplies seem to make a difference for this particular virus in a very good way for us. So a caller from Duluth wants to know, though, if we're using UV light to sterilize masks. And there's been a lot of talk about this.
And we are doing that. There's been a well-validated process identified at several centers throughout the United States. And we use UV light to clean rooms generally when we're not in the midst of this pandemic. Now what we do is, and again, it's not that we don't have enough masks. We do have enough, and we will be using our supply of new masks first, but we know that the supply is limited, and so we have a process whereby providers and nursing staff who are in direct patient care, they will turn in a mask. It gets turned in a brown paper bag. It's treated overnight, and then it gets back to that provider in a white paper bag. It's a signifying clean. Again, we're doing this with an eye towards the future and a potential surge, making sure that we have appropriate PPE when we need it.
We're doing something very similar.
Yeah.
With UV light, yeah. It seems to be the least damaging to the mask.
Well, and so I thought what would be interesting, because we have several questions about masks, and thinking a little bit about helping everyone recognize that those of us who are in a hospital environment have to be what's called fit tested for a mask, this N95 mask, to make sure, and it's a fairly involved process to ensure that there isn't any way that it can get around the sides of the mask. And so the idea of being able to reuse those is really, I think it's been really helpful for all of us, recognizing that once you're fit and you get one that feels good, you'd like to get that one back, I think. And that for men in particular, they're asking people to shave. And I think that's something that maybe not everybody's aware of. So maybe if your physician normally has a beard, maybe not right now.
You should see the mustaches we have now.
Yeah.
It's really interesting.
Yeah. So we had a writer come in this week wanting to know actually a fairly simple question, which is which side of the paper mask goes on the outside, blue or white? So if you don't work in a clinic or if you don't work at the hospital, you're not familiar with these masks. But if you have someone who gave them to you, if you got the blue and white one, which side goes next to your face?
The white in general.
Yep.
So.
And the good news is that they generally are bowl-shaped, and so they help in that regard. But yeah, the white is my understanding, and I'm not sure about this, but is that it's a kind of a water-resistant outer covering. That's why it's there.
Yep. So there's one question that I wanted to get to that was called in last week, and I thought the two of you would be really ideal to answer this. And it has to do with a healthcare directive. If someone says that they don't want to be put on a respirator in the case of serious illness, does this mean that they won't be given a ventilator if they come down with the COVID-19 illness?
I would think yes. I mean, that's what the whole idea of that if you got so sick that you needed a respirator, and we've talked about this when you're well, and you said, I don't want a respirator, then we wouldn't use one.
But what if you change your mind?
Now that is their decision at the time. And a lot of times, if you can, every time you come into the hospital, and especially a situation like that, we'd review that with them, saying, what are your wishes now? This is what you told us before. Is this still the same? And so that's in general what we try and do every time. It gets tricky. It gets very tricky if a patient has their wishes expressed. They are no longer able to give us an answer.
Okay.
And then it sometimes has to default back to the family, and it gets very tricky. Hopefully the family, the biggest thing is those people who have made that decision, relay that to the people who will then make that decision if they can't.
Well, and I was going to ask Dr. Van Deelen to comment too, as an ER physician, knowing when people come in and may not be able to speak for themselves, the things that you might do to sort of find out.
Yeah, so I think, so there's several things that we do. We have worked with our long-term care providers and nursing home providers to ask that that process take place, that there is a clear discussion with patients so that they're able to, in a relaxed setting when they can think clearly, specify what their wishes are. We ask that that be placed prominently on their chart when they're transferred. We also have an electronic marking on their chart that we refer to. And then there's always a family contact, a decision maker, and if we can't find a clear designation anywhere else, we'll call them day or night. I think the other thing that's important is that if somebody designates themselves as not wanting to be on a ventilator, that doesn't mean that we don't treat them. We really are focused on making them as comfortable as they can be. And sometimes that's an important thing that people should know.
Sure. Well, we're coming at the very end of the show, and I've got one last point that I think we can all make, and that was, you brought this up, Dr. Van Deelen. We have a question from Duluth that says, if you're scheduled for a port treatment for your cancer, for a chemotherapy treatment, should you go in? It's our last bit.
Yes.
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 So with that, I really want to thank you both, Dr. Ken Ripp and Dr. Nick Van Deelen, and our phone staff and crew for being here this evening. Please join me again next week when our guests will include Amy Westbrook, Public Health Division Director for St. Louis County. Thank you for watching and have a healthy week. Wash your hands.